Welcome to the deep dive. Imagine a class of hormones so fundamental to human life, so potent in their effects, that synthetic versions have become indispensable. They treat just an astonishing range of conditions across, well, virtually every medical field. We're talking everything from calming chronic inflammation and asthma to life-saving interventions in emergencies like, say, anaphylaxis, even supporting organ transplant patients or aiding fetal lung development. Their reach is just immense. But, with anything so powerful, this utility comes with significant complexity and often substantial challenges that really demand careful, nuanced management.
Yeah, it's really fascinating because these compounds aren't just like external medications we take. They're essentially mirror images of hormones our own bodies produce naturally, always working behind the scenes. They're responsible for some of our most critical physiological processes, fine-tuning metabolism, orchestrating stress responses. So understanding their intricate dance, right down at the cellular level, is absolutely key. It helps grasp their widespread clinical utility and also the profound considerations we need to make, especially when they're used as medication, often at doses much higher than our bodies naturally produce. That's where the complexity really kicks in.
Precisely. So today our mission in the deep dive is to embark on a truly comprehensive exploration. We're tackling adrenocorticosteroids and adrenocortical antagonists. And this isn't just scratching the surface. We're aiming for that deep, detailed understanding, the kind of mastery elite professionals possess. We'll dissect these essential steroid hormones, their synthetic counterparts, explore their precise mechanisms of action, uncover their profound effects, delve into their crucial clinical applications, and critically, scrutinize those extensive side effect profiles and complex drug interactions. It's a big topic.
It is. And to get that level of depth, we've pulled from some really authoritative sources. Our foundation is KATZUNG and Trevor's Pharmacology, sort of the definitive textbook. We're also bringing in insights from clinical sources like Stat Pearls and Cleveland Clinic, very reliable, plus specialized clinical practice guidelines like the Society for Endocrinology's guidelines for Addison's disease, and a systematic literature review on the long-term impacts of corticosteroid exposure. And to really ground this, we're looking at a specific study from Banyumas Hospital in Indonesia. It explored drug interactions in COVID-19 patients, gives a real-world glimpse of pharmacology in action during a crisis.
Okay, great. So our goal today is to equip you, our listener, with the sophisticated insights needed to truly master this information. You'll gain a granular understanding of how these powerful compounds work, their benefits, risks, how they interact, and ultimately you'll understand why healthcare professionals manage their use with such, well, extreme precision and care. So let's start at the beginning. Let's demystify what these corticosteroids actually are.
Right, so at their most basic, corticosteroids are a class of steroid hormones. They're naturally produced by the adrenal cortex, that small organ sitting on top of each kidney. These hormones play fundamental roles, acting like critical conductors in our body's internal orchestra, maintaining balance, managing stress responses.
And you mentioned there are two major groups within this category with distinct roles.
Exactly. First, we have the glucocorticoids. These are probably the ones most people think of when they hear steroids in a medical context. Their primary effects are broad, impacting carbohydrate, fat, and protein metabolism significantly. They're heavily involved in catabolism, breaking things down, and crucially, modulating our immune responses and inflammation. In fact, glucocorticoids, like our natural cortisol, are often called our primary stress hormones. They're absolutely essential for life, helping us cope with, well, everything.
Okay, so glucocorticoids handle metabolism, stress, inflammation. What about the second group?
The second group is the mineralocorticoids. Their role is more focused, but just as vital. Their main job is regulating sodium and potassium reabsorption, primarily in the kidney's collecting tubules. This is critical for maintaining the body's fluid and electrolyte balance, which directly impacts blood pressure. The main natural mineralocorticoid is aldosterone.
Right, so just to clarify the terminology, because it can be confusing, when doctors or pharmacists talk about corticosteroids or just steroids, what are they usually referring to? And how is that different from, say, anabolic steroids?
That's a really important distinction to make. Great question. While corticosteroids is the umbrella term for both groups, in day-to-day practice, when clinicians say glucocorticoids or simply steroids, they're almost always referring to the compounds used for their potent anti-inflammatory and immunosuppressive effects. It's crucial, absolutely crucial, to distinguish these from anabolic steroids. Anabolic steroids are synthetic forms of testosterone, used for totally different reasons: muscle building, performance enhancement. They have their own set of effects and risks, completely separate from the corticosteroids we're discussing today, for inflammation and immune control. Not the same thing at all.
Okay, that clears things up. Now let's get into the mechanism. This is where it gets really interesting, isn't it? You said it's like a precisely choreographed dance inside our cells, telling our genes what to do. How does that work? Let's really dive deep here.
Yeah, this is the core of their power. Understanding this is key to grasping their systemic impact. So when a corticosteroid enters a cell, it doesn't just, bump around on the surface. It goes on a journey. First, it binds to specific cytosolic receptors in the cell's cytoplasm. Think of it like a lock and key. The steroid is the key. The receptor is the lock. Perfect fit. Now, before the steroid binds, this receptor is usually held inactive by stabilizing proteins like HSP90. Keeps it waiting.
Okay, so the key fits the lock. What happens next? Where does this complex go?
Once the steroid binds, those stabilizing proteins let go. That's the crucial step. The steroid receptor complex then undergoes nuclear translocation. Basically, it travels into the cell's nucleus. Often it does this as a dimer, two complexes joined together. And once inside the nucleus, this dimer complex acts directly on our DNA. It binds to specific sequences called glucocorticoid response elements, or GREs, or mineralocorticoid specific elements for those.
Wow, okay, so it's actually interacting with our genes. That sounds fundamental. What's the direct outcome of binding to those GREs?
Exactly. It is fundamental. By binding to these GREs, the complex directly alters gene transcription. This means it can either ramp up or dial down the production of specific messenger RNA, or mRNA, molecules. These mRNA molecules carry instructions to the cell's machinery to make specific proteins. So the net result, the cell's entire protein production profile, and thus its function, gets profoundly changed. For example, in inflammation, it reduces the production of pro-inflammatory stuff, cytokines, chemokines, enzymes, and it can also activate genes that produce powerful anti-inflammatory proteins like lipocortin-1. So it's not just putting a Band-Aid on inflammation, it's fundamentally rewiring the cell's instructions. That's why they're so powerful.
Incredible. But wait, how does that explain why, say, lung tissue responds differently than skin tissue to the same steroid? There must be some fine-tuning, right?
There absolutely is, and that's the elegance of tissue specificity. Even though the hormone receptor complex itself is the same, the specific response in each tissue depends on different protein regulators present there. These regulators are like assistant conductors. They control how the hormone receptor complex interacts with the GREs in that specific tissue context. So the lock and key gets it to the DNA, but these regulators fine-tune the response. It's highly sophisticated. And it's worth noting, while this genomic mechanism involving gene expression is key, there are also rapid non-genomic effects. These happen much faster. Within seconds or minutes, they involve interactions with receptors, maybe on the cell membrane, kicking off cascades that quickly inhibit inflammatory players like phospholipase A2. So it's attacking inflammation on multiple fronts, changing the blueprint long-term, and hitting rapid cellular processes too.
Okay, that paints a really clear picture of the control they exert, right down to the genetic level. Given that depth, it makes total sense they'd have such widespread effects on organs and tissues. Almost everything must be touched by this. Let's start unpacking those effects. What about the metabolic impacts? What are the key takeaways there?
Yeah, their metabolic effects are significant and really critical to understand for clinical use. Glucocorticoids are master regulators here. They strongly stimulate gluconeogenesis, that's the liver making new glucose from things like amino acids, so blood glucose levels go up. To get those amino acids, they also promote catabolism of muscle protein, breaking down muscle. And as blood sugar rises, the pancreas responds by stimulating insulin secretion, trying to manage that glucose surge.
So raises blood sugar, breaks down muscle, affects insulin. What about fat? You hear about weight changes with steroids.
Right. Fat metabolism is interesting because it's a dual effect. Glucocorticoids stimulate both lipolysis, fat breakdown, and lipogenesis, fat creation and storage. But the net result, especially with prolonged use or high doses, is often a net increase in redistribution of fat. It tends to deposit in specific areas, leading to the classic moon faces, that round puffy face or a buffalo hump, fat on the upper back and shoulders. These physical signs are really characteristic of chronic steroid exposure or Cushing syndrome. That fat redistribution is a hallmark.
And you mentioned catabolism, the breaking down.
Yeah.
What else gets broken down besides muscle?
Beyond muscle, high concentrations of glucocorticoids cause a wasting effect on various tissues. This includes lymphoid tissue, connective tissue, fat in some areas paradoxically, and skin. That's why long-term users might notice skin thinning, easy bruising, fragility. But crucially, the catabolic effects on bone are a major concern. They lead to osteoporosis. This significantly increases fracture risk, sometimes even with minor bumps. It's a serious side effect. And in children, another big catabolic effect is reduced growth. It can impact their final height, delay puberty.
That definitely sounds like a significant trade-off. But let's talk about the desired effects. The reason they're used so much managing inflammation and immune responses. This is where they really shine clinically, right?
Absolutely. This is their core value proposition in medicine. Their immunosuppressive and anti-inflammatory effects are why they're indispensable. They achieve this mainly by inhibiting cell-mediated immunity, especially involving lymphocytes. They're actively lymphotoxic. They can redistribute or even kill certain lymphocytes. This makes them vital in treating blood cancers like leukemia and lymphoma. And what's quite remarkable is they can delay rejection and organ transplants without completely wiping out normal acquired immunity needed to fight infections. It's a delicate balance.
Okay, so how do they actually suppress inflammation at the molecular level? It sounds like it's not just one thing they do.
No, it's definitely multimodal, highly effective. It starts with promoting the synthesis of lipocortin-1. This protein then suppresses phospholipase A2. That enzyme, phospholipase A2, is critical for releasing arachidonic acid, which is the precursor to tons of inflammatory mediators. So by blocking that, they effectively block eicosanoid production, things like prostaglandins and leukotrienes, key drivers of inflammation. This also directly inhibits prostaglandin synthesis in the COX enzymes, COX1 and TOX2, further dampening the inflammatory cascade.
And what about their effects on the actual blood cells involved in immunity?
Right, they directly impact blood cells too. They induce lymphocytopenia, meaning fewer lymphocytes circulating in the blood. This is mostly due to redistribution moving them out of the blood and into lymphoid tissues rather than outright destruction, at least initially. A single dose can do this within hours, though levels usually bounce back in a day or two. They also decrease monocytes and eosinophils, which normally flock to sites of inflammation. But interestingly, they cause neutrophilia, an increase in neutrophils in the blood. This happens because they push more neutrophils out of the bone marrow, stop them from leaving the circulation, and detach ones stuck to vessel walls.
So connecting this all together, these widespread effects explain both their power and their problems.
That's exactly it. These profound effects on metabolism, immunity, cell function are why they're such potent tools. They can rapidly dial down dangerous inflammation and immune responses. But that same broad reach means they impact nearly every organ system, leading to that significant potential for side effects. It's why using them is always a balancing act, weighing the undeniable benefits against the very real risks. This is the challenge and the art of using these drugs effectively.
Okay, that's a very clear picture of glucocorticoids. Now let's switch gears slightly to the kidney's conductors, the mineralocorticoids. You mentioned aldosterone and its role in fluid and electrolyte balance. How does that work, and what happens when we use drugs to block it?
Right, aldosterone is the main player here, crucial for blood pressure via fluid and electrolyte control. Its main stage is the distal convoluted tubule of the kidney, specifically the principal cells there. Inside these cells, aldosterone does a couple of key things. First, it upregulates the Na plus K plus ATP pump on the basolateral membrane, the side facing the blood. This pump pushes 3 sodium ions out into the blood for every 2 potassium ions it brings into the cell, creates a sodium gradient. At the same time, aldosterone encourages ENaC channels, epithelial sodium channels, to move to the apical membrane, the side facing the urine. These channels let sodium flow into the cell from the urine, down that gradient the pump created.
So sodium flows in from the urine side, gets pumped out to the blood side, a continuous reabsorption loop.
Exactly. It's a coordinated effort. Sodium gets vigorously reabsorbed from the tubule back into the body. And where sodium goes, water tends to follow, mainly via channels called aquaporins in the collecting duct, osmosis. So the net result is increased salt and fluid retention. This increases blood volume and consequently increases blood pressure. You can almost picture that kidney nephron diagram, see the pumps and channels working together.
That makes aldosterone sound very powerful. So if that's what aldosterone does, then the antagonists, the MRAs, must do the opposite. How do they work as counterregulators?
Precisely. Mineralocorticoid receptor antagonists, or MRAs, are synthetic steroids that compete with aldosterone. They bind to the same receptor sites, but crucially, they don't activate them. They just block aldosterone from binding. The main ones we use clinically are spironolactone and eplerenone. And because they counteract aldosterone's effects, they're used in various cardiovascular conditions. They're important in heart failure to reduce fluid overload and harmful cardiac remodeling. Also used after a heart attack, myocardial infarction, for better long-term outcomes. And very importantly, in resistant hypertension. That's when blood pressure is still high, even when someone's already on multiple other drugs, typically a thiazide diuretic, an ACE inhibitor or ARB, and a calcium channel blocker. MRAs are often the next step. They're also key for aldosterone-mediated hypertension, like in primary hyperaldosteronism or secondary excess from conditions like metabolic syndrome or sleep apnea.
Okay, so they interrupt that whole fluid retention cascade. Can you connect their mechanism for blood pressure specifically back to the RAAS system?
Absolutely.
Yeah.
Quick refresher on the renin-angiotensin-aldosterone system, RAAS. Low blood pressure triggers renin release, leading to angiotensin II formation, which tells the adrenals to release aldosterone. Aldosterone then boosts sodium and water retention, raising blood pressure. MRAs jump in right at the end. They block aldosterone from binding to its receptor in the distal tubule. This leads to a reduced sodium concentration gradient. Less sodium gets reabsorbed from the urine back into the body. And critically, because less sodium is reabsorbed, less potassium is excreted into the urine. That's why they're called potassium-sparing diuretics. Very important clinical point. The overall effect: increased sodium excretion, natriuresis, potassium retention, and mild diuresis, water loss, all leading to lower blood pressure.
Makes sense. Now, how do these MRAs behave in the body? Their kinetics and dynamics. Are spironolactone and eplerenone interchangeable, or are there important differences?
There are definitely important differences that influence clinical use. Let's take spironolactone. It's actually a prodrug. It needs to be metabolized into active forms, mainly cameronone and 7-alpha-spirolactone. Spironolactone itself has a short half-life, maybe 4 hours, but its active metabolites stick around much longer, 12 to 20 hours, so the effect lasts. Eplerenone, on the other hand, is metabolized by the CYP3A4 enzyme system in the liver into inactive metabolites. Its half-life is shorter, around 4 to 6 hours.
So even with those half-lives, the effect on blood pressure lasts longer. Why is that?
That's a key point. The blood pressure effect outlasts the drug's presence. Because they're blocking a hormone, aldosterone, which itself triggers downstream effects, changes in gene expression, protein synthesis, remember. Those downstream effects take time to ramp up and time to wind down. Our sources suggest the blood pressure lowering effect can persist for up to 4 weeks, even after stopping the MRA. Needs careful management. For typical hypertension dosing, spironolactone might be 50-300 milligrams daily. Eplerenone is usually 25-150 milligrams twice daily. And there's a pretty linear dose response. Higher dose generally means more blood pressure reduction.
Okay, so we've dissected how MRAs work. Incredible tools, but like glucocorticoids, they have their own quirks. Which brings us to the crucial question. How do we balance the benefits with their specific side effect profiles, especially thinking about spironolactone versus eplerenone? What are the downsides?
Right. This is where the choice between them often comes down to side effects. Spironolactone has a notable issue because it also binds to androgen receptors. It has anti-androgen activity. This can lead to side effects like gynecomastia, breast enlargement in men, and low libido in both men and women. That can be a real deal breaker for some patients, and this is the key advantage of eplerenone. It has much less affinity for those androgen receptors, so it causes significantly fewer of those hormonal side effects. That often makes it a preferred choice if those side effects were a concern.
Okay, so that's a major difference. Are there side effects they both share related to how they work on the kidneys?
Yes, definitely. Because they are potassium sparing, the most significant shared risk is hyperkalemia, high potassium levels. This requires regular monitoring of electrolytes, as severe hyperkalemia can affect the heart and be dangerous. They can also contribute to acidosis, specifically type IV renal tubular acidosis. Aldosterone normally helps excrete acid, H+, and make bicarbonate, HCO3. Blocking it disrupts this balance. Less commonly, but possible, are volume depletion and acute kidney injury, especially if things aren't monitored closely or if the patient has other risk factors. And more general side effects can include diarrhea, nausea, vomiting.
And what about drug interactions? Are there other common meds that can make that hyperkalemia risk even worse?
Absolutely. This is critical. Combining MRAs with other drugs that raise potassium is risky. This includes common blood pressure meds like ACE inhibitors and ARBs, also the diuretic amiloride, the antibiotic combo trimethoprim sulfamethoxazole, often called Septra or Bactrim, and even chronic use of NSAIDs. Mixing these significantly increases the risk of dangerous hyperkalemia. Requires a very careful medication review.
Okay, let's zoom back out to the broader class, glucocorticoids, and tackle that double-edged sword. Their applications are incredibly broad. It's astonishing how many conditions they treat. Truly versatile.
They really are. Used in almost every field of medicine, by almost every route. We can think about their roles in 2 ways, endocrine and non-endocrine. In endocrine roles, they're used at physiological doses for replacement, like in Addison's disease, congenital adrenal hyperplasia, or diagnosing Cushing syndrome, just replacing what's missing. But their more common use involves supraphysiological doses and non-endocrine roles. Here, we're deliberately using their potent anti-inflammatory and immunosuppressive effects. The list of indications is huge. Just to give you a flavor: Allergy pulmonology, asthma COPD flares, anaphylaxis, hives, severe rhinitis, pneumonitis, sarcoidosis, interstitial lung disease. Dermatology, contact dermatitis, autoimmune blistering diseases like pemphigus, gastroenterology, inflammatory bowel disease, Crohn's, ulcerative colitis, autoimmune hepatology, hemolytic anemia, leukemias, lymphomas, ITP, idiopathic thrombocytopenic purpura, rheumatology, rheumatoid arthritis, lupus, polymyositis, dermatomyositis, polymyalgia rheumatica. Heavy reliance here. Ophthalmology, uveitis, keratoconjunctivitis, and beyond that. Organ transplantation, preventing rejection, antenatal lung maturation and preemies, certain nephrotic syndromes, reducing cerebral edema like around brain tumors, treating MS relapses, and even local injections for things like carpal tunnel, bursitis, tendonitis. It's everywhere.
Truly remarkable breadth. And how are they typically given? And what are the immediate, compelling benefits that make them a go-to, despite the risks?
The administration routes are varied to match the need. Parenteral, IVM, for fast, systemic action. Oral for convenient systemic use. Inhaled for lungs. Topical for skin. Injected into joints, lesions, skin. Even rectal for local GI issues. A key clinical principle is always to use non-systemic therapy whenever possible, like an inhaler instead of pills for asthma. Minimize body-wide exposure, minimize side effects. That's the goal.
And the benefits that make them so compelling, why reach for them first?
The benefits are often dramatic and immediate. They offer fast-acting anti-inflammatory effects, often the quickest way to cool down inflammation. This means a quick reduction in pain, swelling, discoloration, huge relief for patients in acute flares. A cortisone shot, for example, can give months of relief, sometimes even resolve the issue, and importantly, they can be potentially life-saving. Preventing kidney failure and lupus or vasculitis, maybe avoiding dialysis or transplant. They buy time and prevent organ damage.
Lifesavers on one hand, but then there's the other edge of the sword. Let's really get into that extensive adverse effect profile. What do people need to watch out for, especially with long-term use?
This is absolutely critical for mastery of these drugs. Their utility is limited by these adverse effects. And it's related to average dose and cumulative duration. Higher doses, longer use, more problems. Up to 90% of patients on them for over 60 days experience side effects. Generally, the synthetic ones like prednisone, methylprednisolone, dexamethasone, betamethasone cause more Cushingoid features and HPA axis suppression. Less of the mineralocorticoid hormonal stuff, potent anti-inflammatories, but prone to systemic issues. Let's break down the major categories. First, a huge concern: osteoporosis, fractures, and osteonecrosis. Steroids impair bone mineralization. Initially, they boost osteoclasts, bone breakdown cells. They reduce calcium absorption. And crucially, they inhibit osteoblasts, bone-building cells, and promote their death. Even low doses, like 5 milligrams of prednisone daily, cause bone loss. BMD can drop significantly in just 3 to 6 months. Increased fracture risk. Osteonecrosis, bone death due to lost blood supply affects 9 to 40% of long-term users, even without osteoporosis. Risk factors like alcohol, sickle cell, HIV add to it.
That's really serious for bone health and often silent until a break happens. What about the body's own hormone system?
Right, that leads to adrenal suppression of the HPA axis. Taking external steroids tells your brain you have enough cortisol, so it stops making its own. Critically, dose and duration don't reliably predict suppression. It varies. Even inhaled or topical steroids can cause it systemically. It becomes obvious when the drug is stopped suddenly adrenal insufficiency symptoms. That's why gradual tapering is usually essential, allowing the axis to wake back up. And this suppression can last a long time after stopping, maybe 9-12 months after high-dose long-term use. Then there are the visible Cushingoid features that look associated with excess cortisol: weight gain, fat redistribution, the buffalo hump, moon face, fat around the torso, truncal obesity. These can develop pretty quickly within the first couple of months. Higher baseline BMI, younger age, higher calorie intake seem to increase the risk.
And the impact on blood sugar and muscles seems like a direct result of those metabolic and catabolic effects you mentioned earlier.
Yes, exactly. Glucocorticoids are the most common cause of drug-induced diabetes. In people already diabetic, they worsen insulin resistance, making control much harder. You see dose-dependent hyperglycemia, often within hours, especially spikes after meals, postprandial glucose. For muscles, it's myopathy, proximal muscle weakness, atrophy. Develops over weeks or months, faster with high doses, usually without muscle pain or tenderness, which is a key point. It's due to that catabolic effect, breaking down muscle protein. Good news is it usually improves and resolves a few weeks after stopping the steroid.
What about vision? Effects on the eyes sound particularly worrying.
Yeah, there's a dose-dependent risk for both glaucoma and cataracts. Glaucoma is more serious. Steroids can raise intraocular pressure painlessly. This can damage the optic nerve, leading to permanent vision loss. The pressure usually normalizes after stopping, but the damage can be irreversible. Cataracts are also common with long-term use.
And mental well-being. That's often overlooked, but can be significant for patients.
Absolutely crucial. Steroids can cause a wide range of psychiatric disturbances. Psychosis, agitation, insomnia, irritability, hypomania, anxiety, mood swings. Interestingly, short courses often cause euphoria, a feeling of high energy. But longer courses can lead to depressive symptoms, sometimes severe. Psychosis is usually linked to high doses, like over 20 milligram prednisone equivalent daily for extended periods. May need antipsychotics. It's a real spectrum.
Given they are immunosuppressants, what about infection risk? Are certain types more likely?
That's the inherent trade-off. The desired effect, immunosuppression, predisposes to infection. The risk goes up significantly with systemic doses over 10 milligard a day. It's influenced by dose, age, underlying illness, and other immunosuppressants being taken. Patients are particularly susceptible to opportunistic infections, invasive fungal, viral infections because their immune defenses are lowered.
Any other major systems affected? Cardiovascular, gastrointestinal, just to round out the systemic picture.
Yes, definitely. Cardiovascular adverse effects are linked to hypertension, hyperglycemia, obesity. Evidence on lipids is mixed. The mineralocorticoid activity varies between steroids, causes sodium water retention and potassium loss, raising blood pressure. Studies link steroid use to higher rates of CV events, new atrial fibrillation flutter, heart failure, ischemic heart disease. For gastrointestinal effects, gastritis, peptic ulcers, bloating, dyspepsia. The ulcer risk from steroids alone is lowish, but it jumps dramatically nearly fourfold when combined with NSAIDs. That's a dangerous combo for the stomach.
And the skin, or effects on growth in kids.
Dermatologic effects, skin atrophy, thinning, fragility, striae, stretch marks usually permanent, purpura, easy bruising. They also impair wound healing, slowing down the migration of immune cells, reducing collagen synthesis. Cuts heal slower. And finally, yes, growth suppression in children and adolescents. Delayed growth, delayed puberty, potentially reduced final adult height. It can also be a sign of adrenal suppression itself. So this whole list really underscores why they're a double-edged sword. Profoundly effective, yes, but their systemic reach demands constant vigilance and understanding of these potential complications.
That is a sobering list. It really drives home the need for caution. So what are the absolute no-goes? When should corticosteroids definitely not be used?
Right, there are clear contraindications. Known hypersensitivity, obviously. Critically, giving live attenuated vaccines while someone is on immunosuppressive doses is a major no. The compromised immune system can't handle it safely. Also contraindicated in active systemic fungal infections, unless that's why they're being suppressed. Pre-existing severe osteoporosis, uncontrolled hyperglycemia diabetes, acute glaucoma, active joint infection, if thinking of injecting into the joint, uncontrolled hypertension, specific eye infections like herpes simplex keratitis, and active varicella, chickenpox, which can become very severe under immunosuppression. Then there are relative contraindication situations needing extreme caution, not absolute avoidance. Active peptic ulcer disease, decompensated congestive heart failure, and viral or bacterial infections not fully controlled by antibiotics and antivirals. In these cases, it's a careful risk-benefit calculation by the clinician.
Okay, given that massive list of potential issues, it's crystal clear why monitoring is so vital. It sounds like a full-time job just keeping track. What does comprehensive monitoring actually involve for these patients?
You're right. It requires immense vigilance, a structured approach. Before starting, a thorough history and physical is essential. Identify pre-existing risks: diabetes, hypertension, heart failure, high lipids, psychiatric issues, osteoporosis. Knowing these upfront helps manage proactively. The core dosing principle is always lowest effective dose, shortest possible duration. Clinicians often try once daily, morning, or alternate day dosing to minimize side effects and mimic the body's natural rhythm.
And what baseline checks are done before treatment even starts to get a starting point?
Good baseline assessments are key. Consider checking height, weight, blood pressure, bone mass density, BMD, a full eye exam, fasting blood glucose, and a lipid panel. Sets the benchmark. For kids, track growth charts carefully. Assess puberty and nutrition due to the growth suppression risk. Bone health monitoring is crucial. BMB at baseline, then maybe after a year. If stable, maybe every 2-3 years after that. Tools like FRAX help decide who needs bone protective meds. For kids, serial BMDs, maybe specialist referral if needed. And always ask about joint pain. Check range of motion for osteonecrosis risk. Plus, advise adults on prevention. Stop smoking, limit alcohol, weight-bearing exercise, calcium, vitamin D.
What about watching for that adrenal suppression? That seems particularly critical, especially when stopping.
Absolutely critical for safety. The team needs to be aware of adrenal suppression risk, especially with 2 weeks of supraphysiological doses. Testing might involve a first morning cortisol level. If that's okay, but suspicion is high, maybe an ACTH stimulation test. If suppression is confirmed, the patient needs daily physiological replacement doses, plus stress doses during illness or surgery, because their body can't respond normally to stress. For GI protection, if someone's also taking NSAIDs or is high risk for ulcers, prophylactic PPI therapy is often used. For skin issues like striae, well, they're often permanent, but diet advice, maybe topical treatments or lasers might be discussed. And for steroids with more mineralocorticoid effect, checking fluid and electrolytes, especially potassium, is important.
Indeed, the vigilance required is huge. So what if toxicity does develop despite monitoring, or when it's time to stop chronic therapy? You said there's no simple undo button.
Correct, no simple antidote. Corticosteroid toxicity is a common iatrogenic illness, especially with chronic use. If it happens, there's no specific reversal agent. Management is about gradual tapering and treating the specific complications, managing high blood sugar, infections, blood pressure, mood issues, etc. As for tapering guidelines, courses under a week, usually stopped abruptly, 1-3 weeks. Tapering depends on the clinical situation, may be needed to avoid disease flare or HPA suppression, longer than 3 weeks. Definitely taper. Usually a quick taper down to physiological doses that a very slow wean while watching adrenal function carefully. Because remember that HPA axis suppression from long-term high-dose use can last 9-12 months after stopping. Patients remain vulnerable.
This really highlights the complexity, especially when other drugs are involved. What are some critical drug interactions healthcare providers must be aware of?
This is absolutely where mastery comes in. Vigilance is key. With warfarin, anticoagulant, steroids can increase its effect. Need closer INR monitoring, possible warfarin dose adjustment, often within days of starting the steroid, bleeding risk. With anti-hyperglycemic drugs for diabetes, steroids counteract their effect. Need more frequent blood sugar checks, likely need to increase diabetes med doses. Antivirals are complex. Some, like efavirenz, reduce steroid effect. Others, like ritonavir, increase steroid effect by messing with metabolism. Needs close monitoring for either too little or too much steroid effect. We mentioned it, but it's worth stressing again. NSAIDs plus corticosteroids is significantly higher risk, almost fourfold, of peptic ulcers, GI bleeds. Avoid if possible, or use strong stomach protection like a PPI. And crucially, live vaccines. Avoid giving these if someone's on immunosuppressive steroid doses, for example, 40 milligram prednisone day for 7 days. Wait at least 3 months after stopping the steroid before giving a live vaccine. This just underscores the need for integrated knowledge across all meds, always considering the full picture.
It's so clear this needs a team approach, not just one person's job. How can the entire healthcare team, doctors, nurses, pharmacists, best collaborate to improve outcomes?
A collaborative approach is essential. Everyone needs to understand these drugs because they're so common and have so many effects. What's therapeutic for one, like raising glucose and adrenal insufficiency, is harmful for another, like someone with diabetes. Monitoring and prevention are key. Patient education is huge. Everyone on the team should be ready to explain the drug, the side effects, the precautions. Empowering the patient is vital. Patients on chronic systemic steroids should ideally carry a treatment card or wear a medical alert bracelet. And using electronic medical record alerts or tags is a great idea to notify everyone involved in their care. A lot of morbidity, even mortality, is preventable with good education and team communication. Which really raises the question for all of us, patients included. How do we ensure that communication happens effectively? It's a shared responsibility.
That's a powerful point about shared responsibility. Now, let's bring this into a very real-world context, the COVID-19 pandemic. Why was this such a crucial setting for seeing complex drug interactions with corticosteroids play out?
COVID-19 was a perfect storm, really. Corticosteroids like dexamethasone became vital for calming the cytokine storm and preventing ARDS in severe cases. Essential tools. At the same time, patients got lots of symptomatic treatments: N-acetylcysteine, paracetamol, omeprazole, ranitidine, ondansetron. The problem was the intersection. These COVID therapies, plus treatments for patients' pre-existing chronic conditions, which often meant polypharmacy, multiple medications already. That scenario dramatically increases the probability of drug interactions.
Right. Treating a new disease in patients often already on multiple meds, then adding powerful steroids, a recipe for potential interactions. Let's look at that Banyuma's hospital study. What did their patient demographics and drug use reveal?
Okay, so this was a retrospective look at 334 COVID inpatients in Indonesia. June 2020, June 2021. Demographics. Slightly more females admitted, 55.7%. The global data often showed higher male mortality. Largest age group was 46-55. Importantly, many patients, 2423334, had comorbidities, mainly hypertension, 35.1%, and diabetes, 23.0%. Consistent with who got sicker. Drug use. Dexamethasone, 70 patients, and methylprednisolone, 15, were the main steroids. Symptomatic meds were common. Paracetamol, 241, omeprazole, 227, and acetylcysteine, 129, ranitidine, 116, ondansetron, 84. And here's the polypharmacy point. Patients were on an average of 5 to 6 meds. The study noted that risk jumped significantly with more meds. Patients on 9 were 4 times more likely to have adverse reactions than those on 5.
5 or 6 meds on average. That really sets the stage for interactions. So what was the overall incidence of potential interactions in the study, and how serious were they?
The numbers were striking. A massive 91.32% of patients had potential drug interactions identified. Nearly everyone. Mechanism-wise, pharmacodynamics, drugs affecting each other's actions, was most common, 53.23%. Then pharmacokinetics, drugs affecting absorption, metabolism, excretion of others, at 38.10%. Some unknown. Severity breakdown. Almost half were minor, 48.99%, likely no real clinical impact. But a big chunk, 40.73%, were moderate, could worsen things, needed monitoring or changes. And critically, 10.48% were major interactions posing significant life risk or potential permanent damage, needing drug discontinuation. Even if many are minor, that overall percentage shows how common these potential issues are in complex care. The need for vigilance is huge.
Let's get specific. Can you walk us through some illustrative examples from this study, both pharmacokinetic and pharmacodynamic ones?
Sure. For pharmacokinetic interactions, how drugs move through the body. Absorption. Paracetamol plus metoclopramide. Metoclopramide speeds up stomach emptying, making paracetamol absorb faster, potentially hitting harder or quicker. Needs monitoring. Metabolism. Paracetamol plus favipiravir. Favipiravir inhibits one of paracetamol's breakdown pathways, raising paracetamol levels. Risk of liver toxicity. Recommendation was to limit paracetamol to 3R day. Excretion. Ranitidine plus metformin. Ranitidine blocks metformin's kidney excretion pathway, MAE1. Metformin levels rise, increasing risk of lactic acidosis. Serious, needs lower metformin dose. Close monitoring.
Okay, those affect how the drug gets processed. What about pharmacodynamic interactions, where they directly affect each other's actions?
Right, some key ones here. Synergism, increased risk. Dexamethasone, methylprednisolone, plus levofloxacin or other quinolone antibiotics. Major severity, significantly increases tendon rupture risk. Both drugs can weaken tendons. Together, it's worse, especially risky for elderly transplant patients. Management, stop the quinolone, avoid strain, watch for tendon pain. Antagonism, reduced effect. Paracetamol plus ondansetron, high incidence. Ondansetron, anti-nausea, blocks serotonin receptors, 5-HT3, that paracetamol might use for pain relief. May need paracetamol dose adjustment. QT interval prolongation, major severity additive effect. The triad of ondansetron plus hydroxychloroquine plus moxifloxacin. Each drug can prolong the QT interval on an EKG, increasing risk of dangerous heart rhythms, arrhythmias. Together, the risk is additive and significant. Management, avoid combo if possible. If not, intense monitoring of EKG, electrolytes, kidney function is crucial. Life-threatening potential.
Wow, that COVID-19 example really drives home the complexity in practice. It's not just one drug, it's the whole cocktail. What were the study's limitations, and what does this mean going forward?
A key limitation is that this study identified potential or theoretical interactions using databases. It didn't track whether these interactions actually caused clinical harm in these specific patients. Many were minor. So the big implication is the urgent need for prospective studies. We need research that actively follows patients to see the real-world incidence and clinical impact of these interactions. That's how we move from theoretical risk lists to practical strategies to actually mitigate serious adverse effects in real patients. Building that stronger evidence base is critical.
We have certainly covered a vast amount today, really gone deep, from the basics of corticosteroids, how they work right down at the gene level, their incredibly broad uses, then navigating that daunting list of side effects, the absolute necessity of careful monitoring, and finally grappling with drug interactions, highlighted so clearly by that COVID-19 study. It's a lot.
It really is.
Yeah.
But the information isn't just, facts and figures. It's about appreciating the body's sophistication and the powerful yet delicate tools medicine uses.
Yeah.
Understanding these nuances empowers everyone, clinicians, patients, to think critically about health and medications.
Yeah.
It's really about moving towards that mastery of understanding.
Absolutely. You now have, hopefully, a powerful, comprehensive understanding of corticosteroids, these pharmacological multitaskers. It's a lot to absorb, but being well-informed means connecting these dots, seeing the power, the risks, the need for careful management. So, thinking about all this, what stands out to you from our deep dive today? How does this change how you might think about these medications?
And looking ahead, given the immense power and widespread use, but also the significant side effects. What future innovations seem most critical? Are we talking about more targeted delivery, maybe new compounds with fewer off-target effects, or perhaps entirely different ways to manage inflammation and immunity that could one day lessen our reliance on these powerful but complex agents? It's definitely something to think about for the future of medicine.